She's one of our specialists she successfully completed her master's in 2017 and also then went on and did laryngology phonosurgery fellowship with us. And part of her training was based in Chulalongkorn University, Thailand, and University of Auckland in New Zealand. So today she's going to give us a talk on vocal cord palsy, why and when to inject. So as we know, vocal cord palsy can have significant effects on quality of life, causing aspiration symptoms and voice dysfunction. So Dr. Tan will highlight what treatment options are available in our center for these patients. So all yours, Dr. Tan. Thanks.
Thank you very much, Prof. J, for the introduction, and a very good morning to everyone. Let me just share my screen first. So a very good morning to everyone. My name is Sien and I'm from the Department of ENT. Today, I'll be talking about vocal cord palsy, why and when to inject. Let me start off the talk by presenting to you one of my patients, case 1. Madam A is a 49-year-old lady, It's a 49-year-old lady who presented with an enlarging neck mass that's progressive over the last 10 years. Further investigations revealed a left carotid body tumor. She underwent excision, and intraoperatively, her left vagus nerve was sacrificed as it passed through the tumor. So post-operatively, she suffered from a very breathy and hoarse voice, and most importantly, she suffered from persistent aspiration, where it was deemed that she was not safe for oral feeding and she needed an NG tube. Okay, let's just have a look at the video next. So this is a scope finding of the patient. So you can see there's a lot of pulling of saliva and the left vocal cord is not moving. And there's also a very obvious phonation gap seen. So the patient was suffering from a very weak voice, breathy, as well as aspiration. So in view of her symptoms, she was offered injection laryngoplasty. This was the video after the injection laryngoplasty was done 2 weeks later. So the scope findings showed that the left vocal cord is bulkier and the phonation gap is now very minimal. So the patient was very happy with the outcome and progressed. She had no more aspiration symptoms and she passed her FEES examination. So she was deemed safe for oral feeding and the NG tube was removed. Her voice also improved. I'm sorry you can't hear the video, but if you could, you can actually appreciate the big difference. So unilateral vocal cord palsy. Let me just talk a little bit more about it. What are the causes of the unilateral vocal cord palsy? One of the most common causes would be iatrogenic and is most commonly secondary to thyroid surgery. Of course, there are other surgeries that can cause it as well, namely the anterior spine surgery, esophagectomy, and cardiothoracic procedures. Another very common cause would be malignancy, such as cancers from the lung, the larynx, the thyroid, and the esophagus. Idiopathic causes are also very common, where we cannot find any organic cause for it, and is postulated to be from a viral infection. Another cause would be trauma, where there is direct injury to the nerve itself, as well as cricoarytenoid dislocation. Intubation injury, neurological causes such as stroke, myasthenia gravis, inflammatory conditions, and infectious disease can also cause unilateral vocal cord palsy. So what is the innervation of the larynx? It's mainly by these two nerves, first being the recurrent laryngeal nerve, which supplies all the intrinsic laryngeal muscles except for the cricothyroid muscle. So these will abduct and adduct the vocal cords, which basically means to open and close the vocal cords. You open to allow breathing, you close to prevent aspiration and also for phonation. The other would be the superior laryngeal nerve, which supplies the sensation to the glottis and the supraglottis. It also supplies the cricothyroid muscle, and this muscle actually tensors of the vocal cord, which controls the pitch and will give rise to the high-pitched voice. So what do these patients complain of when they have a unilateral vocal cord palsy? It depends on how severe it is. In mild cases or where the patient where is well compensated, there is almost no phonation gap or very minimal gap. So these patients would have a near normal voice or just experience some vocal fatigue. In cases where the vocal cord is atrophic or poorly compensated, there would be a large phonation gap, and this will result in a breathy and weak voice. Some of these patients do improve over time. They will develop compensatory strategies. And in the scope, we can see what we call the supraglottic hyperfunction. So laterally, the false cords will try to oppose and to close the phonation gap. Anterior posteriorly, the epiglottis will oppose to the arytenoids. In some patients, especially female patients, they would present with a high-pitched voice. This is what we call the paralytic falsetto. This is due to the compensatory cricothyroid muscle contraction. This happens in cases where there is isolated recurrent laryngeal nerve injury, where the superior laryngeal nerve, which supplies the cricothyroid, is preserved. Patients also complain of aspiration. This could bring about to devastating effects, leading to pneumonia where they require hospitalization for IV antibiotics. So how do we manage unilateral vocal cord palsies? First, we can always try the conservative method, where we observe the patient for 9 to 12 months in the hopes that the palsy does recover. In the meantime, we can refer to speech therapy to strengthen the vocal cord muscles and hopefully to improve the voice and prevent aspiration. The advantages of this method would be that the nerve may actually recover on its own, or even if it doesn't start to move and remains immobile, the patient will eventually compensate and develop the compensatory techniques which I mentioned earlier. The disadvantage of this would be that there could be a possible long waiting period of 9 to 12 months. This can affect the income of patients who have high vocal demand, those who need their voice for their livelihood, such as lawyers. The quality of life, because as we know, for Muslim patients, they actually need their voice for prayers. So all these actually affect the quality of life very much. And most importantly, it can also cause aspiration, leading to pneumonia while waiting for compensation or for the nerve to recover. Second option would be injection laryngoplasty. So the advantages of this is that early intervention can be done. There is no need to wait to see if the nerve will recover. We can actually do it early as a few weeks, intraoperatively, or a few months. There is no hard and fast rule as to when you can do it. These are especially good for patients with a high voice demand, such as teachers, salespeople, as I mentioned earlier. It can also prevent aspiration, which would then prevent pneumonia and hospitalization. And this technique can actually be done in the clinic setting. So there's no need to go for OT for the injection. The disadvantages of this method would be it's only temporary. So after a few months or a few weeks, depending on the material that we use, we may have to re-inject again. The materials that we use are also expensive, and they cost usually more than 1,000 ringgit. And it's also only suitable for certain cases where the phonation gap is small, only 1 to 2 meters maximum. If the phonation gap is too big, this method is not suitable. Since this method is also done in the office, in the clinic setting where the patients are actually alert, the patients may feel anxious. So sometimes these procedures are not suitable for those who are very, very anxious. The third method would be open thyroplasty. This is a type 1 Ishiki. So the advantages is that it is permanent, so you don't need to redo again. It's cost effective because the material that we use is either silicone block or Gore-Tex, which is not very expensive. And since it's meant to be a one-time procedure, if no complications occur, that is, then the patients do not need to keep paying over and over again to repeat the procedure. It is also suitable for those with a big phonation gap of 3 millimeters. The disadvantage of this method is you need to wait after 9 to 12 months. Why is this so? Because it's a permanent method and it's actually a surgical intervention. You need to see whether the nerve actually recovers or not. After 9 to 12 months, it's very unlikely the nerve will recover, and then you can opt for the open thyroplasty method. It needs to be done under daycare, and throughout the whole procedure if they are very aged. Also complications where the implant can actually extrude or can cause some infection. In cases like this, then a revision surgery may need to be performed to remove the implant and to reinsert back, either in the same setting or a few months later. So the last one is the most interesting development called the recurrent laryngeal nerve innervation. The non-selective method uses the ansa cervicalis, which is part of the cervical plexus, and this is anastomosed to the recurrent laryngeal nerve. The advantages of this that it is permanent, is an alternative to open thyroplasty. So it's actually suitable for pediatrics compared to open thyroplasty. And it restores the muscle tone and bulk to the paralyzed site. So remember, it only restores the tone and bulk. It doesn't cause the nerve to move again. So the disadvantage is that there is still no coordination between the respiration and the phonation. This method requires GA, so it needs to be done in the OT setting. And there is actually a delay, whereby after the procedure, you have to wait for 6 months before you can notice any voice improvement. So while waiting, since 6 months is quite long, you can inject first. Okay, so let's talk a little bit more about injection laryngoplasty. Why and when? Why is it done? Although it's temporary, it can improve aspiration and voice requirement for the patient, especially those with a high vocal demand. It is also suitable when the prognosis for recovery is uncertain. So while waiting, as I mentioned, 9 months, 12 months, it is actually very good to inject first. So at least the patients who have good quality of life, they can communicate and they will not suffer from aspiration in severe cases. It is also done as a trial basis, whereby we can see if there is some medialization and there is no more phonation gap. If they produce good results and there is good voice outcome, then we can opt for permanent correction, which is the open thyroplasty method. And sometimes after open thyroplasty is done, there may be a residual minimum phonation gap. So this can be used as an adjunct, whereby it's called a touch-up procedure. So when can we do it? There is no hard and fast rule when we can do it. Sometimes you can even do it intraoperatively when we know that the recurrent laryngeal nerve is severed or is intentionally sacrificed, usually in cases of cancer. It can also be done from weeks to a few months post-operatively. All this actually depends on the patient's aspiration symptoms and their voice requirement. So it is very important to discuss with the patient and counsel so that they can decide whether or not they want to proceed or they want to wait. So what and how? What are the materials that we can use for the injection? The materials are further divided into short-term and long-term. How is it done? Well, it's definitely done in the clinic setting most of the time, and it can be done via the percutaneous route, where it is injected through the neck, or transoral route, whereby it's injected directly into the vocal cord via the port through a scope. So let's talk a little bit more about the short-term materials. Hyaluronic acid, I'm sure many of you have heard of this. It's mainly used in the aesthetic clinic, where it gives moisture and plumping your skin and all. But it's also used by us. And the most commonly used is Juvederm. Other brands include Torsal and Restylane. The price of Juvederm is not cheap. One box ranging from 1,400 to 1,500 plus. And in one box, there is actually 2 mils. 1 mil of syringe, so 2 syringes in one box. The resorption rate is from 4 to 6 months, meaning after we inject, the outcome may disappear after 4 to 6 months. The amount that we use ranges from 1 mil to 2 mils. So if the patient only requires 1 mil, then one box technically can last for 1 year. This is considered an off-label use. Other short-term materials involve carboxymethylcellulase or Radius. This is FDA approved, but the resorption time is much faster. Lasts for only 4 to 6 weeks and 2 to 3 months. So among all the short-term materials, it is quite obvious that hyaluronic acid is the most popular and most widely used because the absorption rate is longer. What about long-term materials? So one of the ones that we can use is autologous fat, meaning fat from the patients themselves. The advantages is that since it's autologous, the patients will not develop any reaction from it. And it's of course cost-effective because you are using your own fat to inject into the vocal cord. And it can actually last up to 2 years depending on the absorption rate. These advantages of this method is that the duration is unpredictable. Some can last up to 2 years, some 1 year, some only a few months. And it actually requires GA, so it needs to be done in the OT setting. Some patients also suffer some morbidity from the fat harvesting. The outcome is quite variable because it's very operator dependent, depending on how you harvest the fat, whether you harvest it properly, whether you prepare the fat properly, and also the correct injection techniques. This method needs a specialized instrument called the high pressure burning syringe to inject into the vocal cord. So this is just a quick overview on how we harvest the fat. We use a method called tumescent liposuction. The solution that we use consists of adrenaline, lidocaine, as well as normal saline. So we just make a small nick underneath the umbilicus. We use a trocar, and then we get the fat out into the syringe. So once we get the fat, we have to filter it and wash away all the hemolyzed red blood cells because we only want the fat. And then we pack it into the syringe, and from there, we can inject into the vocal cords. For this method, aggressive overcorrection is usually recommended. So some people will over-inject up to 80 to 100% more because it tends to resolve very quickly. Another long-term material will be calcium hydroxyapatite. It lasts from 2 to 5 years, and this is actually FDA approved. However, it does cause some inflammatory reactions, and it is also more rigid. So the outcome is not so good, especially where voice is concerned. Teflon was also a long-term material that is now no longer used. Because it causes a lot of complications, such as inflammatory reactions and granuloma formation, which can actually injure the vocal cord. So we don't use it anymore. So how is the procedure done? It is done in the clinic, and I'll be talking more about the percutaneous technique, which is normally done in our center. First, the patient is seated on the chair, and then the lignocaine 1% is injected into the skin at the area where we want to insert the needle. Lignocaine 2% is sprayed at the larynx. We can either use it straight into the larynx via the atomizer, or we can inject through the neck into the larynx and ask the patient to cough. Where do we inject? Okay, so for percutaneous, it is through the neck. There are 3 ways, either between the thyroid and the hyoid bone. So this is called the thyrohyoid membrane, or through the thyroid cartilage itself. The last method would be through the cricothyroid membrane. The one that I normally use is the thyrohyoid membrane puncture, so between the hyoid bone and the thyroid cartilage. We use the scope to visualize where we're going to inject. And the needle that we use is just a normal green or the orange needle, either the 21 gauge, which is a smaller orange needle, or the 25 gauge, which is a green needle. The length of the needle is very important. It needs to be at least 1.5 inches, otherwise it cannot reach the site where we want to inject at the vocal cord. Injection is done lateral to the vocal cord, anterior to the vocal process. So roughly about anterior 2/3, posterior 1/3. The amount that we use depends on the patient, depends on the size of the phonation gap. Normally, I find that 1 ml is enough, but in small selected patients, maybe 1.5 ml. Slight overcorrection is recommended. So this is the short video just to show how the injection technique is done. So with the aid of the scope, so we can see the needle comes out just above the vocal cord in the center, and the needle is actually lateral to the vocal cord, anterior to the vocal process. As the material is slowly injected, we can see the vocal cord that is not moving on the left side. It's the right side on the screen is slowly getting more bulky, and the phonation gap will slowly decrease. This procedure is actually tolerated quite well by the patients as long as we anesthetize the larynx. The patients won't get very minimal bleeding and considered very fast, maybe about 15 minutes, a bit longer, a bit less, depending on the patient's cooperation. So the results, the patients are actually very happy most of the time. There is good outcome, fast results. Aspiration is usually relieved immediately, whereas for the voice, we need to wait about 2 weeks for the material to slowly disperse and even out on the vocal cord. Patient satisfaction is high, and the follow-up is about 4 to 6 months later, even longer, depending on the patient. They will come back once the voice goes back to the original not so good state. So what are the problems that we can encounter with this method? First would be under injection. If you don't inject enough, then there will be a phonation gap. The patient won't get a very good outcome. Sometimes if the needle can go down into the subglottic area, then the material can extrude out. So this will also cause under injection. Over injection can also occur when you inject too much. The problem with this is the patients would have strained voice. So even if the phonation gap is closed, it will be too tight. So the patients would have a strained voice and may even complain of worsening voice after the injection. For this, unfortunately, nothing very much can be done. Thankfully, it's a temporary procedure, so we just have to wait for the material to reabsorb and disappear. The posterior gap also cannot be resolved with this injection method. For this, you need other procedures such as arytenoid adduction. This is also a multidisciplinary approach. So most of the time, you need the speech therapy to improve the patient's voice outcome. So some patients have very strong gag reflex. They may be unable to tolerate the procedure. In this case, LA is very important. So we can actually use the nebulizer method. So instead of just spraying the lignocaine onto the larynx, we can actually also put it in a nebulized solution. So the patient would breathe in and out the lignocaine solution through the nebulizer. I find that this technique actually really well anesthetizes the larynx very well. Patient anxiety is also an important factor if you want the procedure to go smoothly, because the patients need to cooperate. So it's important to counsel the patients properly. I find that if you explain to them what you're going to do, what they will experience during the procedure, and what they're going to experience after, they are a lot more calm and they actually are able to tolerate this procedure. One thing we need to be careful of is hematoma. So for those on antiplatelets, I tend to stop the medication 1 week prior to that. So what are the alternatives besides the injection thyroplasty? We also do open thyroplasty methods. Let me present the second case to you. A 73-year-old lady with a thymus tumor underwent thymectomy. Unfortunately, it was complicated by a left vagus injury. She complained of aspiration symptoms and suffered a breathy, soft voice. She refused injection laryngoplasty in view of financial constraints. As I mentioned, the materials are expensive and also needs to be bought repetitively because the effects are only temporary. So she opted for open thyroplasty, which was done under LA in daycare. So this is a video before the open thyroplasty was done. So you can see the left vocal cord on the right side of your screen is not moving and there's an obvious phonation gap. So for the open thyroplasty method, we actually insert an implant. Could either be a silicone block that we carved out or Gore-Tex. So the video post-op, we can see that the vocal cord is medialized and there is no more phonation gap or very minimal at the posterior gap. The patient was very happy with the procedure. Outcome was quite good. There was no more aspiration. The voice improved. It was louder, less breathy, and the patient is now undergoing speech therapy to further improve the voice. So injection or open thyroplasty. From my point of view, injections are actually very good. They can be done in the clinic setting. There's no need for any daycare facilities. It's a less invasive method and done very quickly. It can also be done immediately or done very early on to alleviate symptoms of aspiration or those patients who requires their voice. So as opposed to open thyroplasty, which is a more permanent procedure, I agree, but we need to wait 9 to 12 months. So I think it's important to counsel the patients properly to discuss the options and see which best suits their lifestyle and their financial constraints. So this is just a few papers from the literature where they advocate hyaluronic acid as an effective treatment for vocal cord palsy. So this is also the one that I mainly use in our center, and I believe it's quite widely used in Malaysia as well. This is just another interesting paper about the early versus late injection for unilateral vocal cord palsy. So it is stated that for those who inject early, before 6 months, they are less likely to require open thyroplasty, which is the permanent correction. Compared to those who inject after 6 months, almost all of them need the permanent correction. So why is this so? It's because when we inject at the vocal cord, so the vocal cord position is at the medial optimized position, and is more likely to maintain when re-innervation happens, this is just a theory, and this is why they think that if you do it early, it's actually better for the patient. This is another paper where there's a systemic review, and they do find that for all centers, most centers, when you do early injection of the laryngoplasty, it actually lowers the risk of thyroplasty. So these patients may actually not need to go for the permanent correction in the end. These are the references I use for my talk, and that's the end of my talk. So I hope you've enjoyed it and found it informative. Thank you.
Thank you very much, Dr. Tan. So that is really interesting to see the evolution of phonosurgery has, come a long way. Now we're doing office-based surgery. There's re-innovation. So it's quite interesting. So let's see what questions we have. Prof. Anna, so she's asked, can I know about indication, efficacy, and outcome in children?
Okay, so for children, it cannot be done in the clinic setting because usually they are not able to tolerate. So for this case, if we choose injection, it can actually be done under daycare. So we put the patient under anesthesia and then we still inject at the same place. So the only difference is that they need to undergo general anesthesia as compared to the patients who are adults, they can do in the clinic setting. Sorry, what was the next question? The efficacy. So, okay, so I haven't actually done it in pediatric patients in my center because I think for pediatric patients, we tend to wait for it to recover. Unless they are experiencing a lot of aspiration symptoms, then we usually send for speech therapy first, and then I think we opt more for the permanent method. So in this case, open thyroplasty is a little bit difficult because it's under LA. So recurrent laryngeal nerve innervation would be more suitable for pediatrics.
Yeah, I agree. I think in large centers like Cincinnati, Philadelphia, the numbers are very small. So really the outcome of injection really varies, varies between 30 to 70%. So it's a large variation depending on each center because the numbers are quite small. Next question, patient with acute unilateral vocal cord palsy post-op, be it thyroidectomy or some CTS surgery, if the gap is huge leading to loss of voice and severe aspiration, which method, injection or open thyroplasty, is more efficient?
Okay, so for huge gap, usually we opt for the open thyroplasty. But as I mentioned, because it's a permanent technique, we actually need to wait for the nerve to recover. So you cannot do it early because in the eventual fact that the nerve recovers, you can't do a permanent, you can't undo it. So injection would be the best method. And although I mentioned that the phonation gap is quite big, but eventually the patients will have some compensation. So they can compensate from a large gap to a smaller gap. So in the end, the outcome, there may be a smaller gap, but it is still better. So the patients do improve quite fast. It's just that for you to have zero, for you to have, like, say, suffer zero effects from the vocal cord palsy, you need to wait up to 9 to 12 months. But they do compensate quite well. So if you want for acute setting, injection would still be the only method. We cannot justify doing an open thyroplasty until 9 to 12 months later. So for aspiration, then most likely we need to consider NG tube feeding, and in the meantime send for voice therapy. And there are the techniques, like if the vocal cord palsy is on the left, the patients are asked to turn to the left and chin tuck. So all these methods, I think it basically is a multidisciplinary approach, and there are like multiple interventions, not only from the ENT side, to actually help relieve the patients while seeing whether or not we have to do a open thyroplasty method. I don't think there is any method that's more efficient. Everything is on case-to-case basis, depending on the patient's requirements, and the timing is actually more important because, injection can be done anytime, but open thyroplasty, you can't.
Okay, so I think that brings us to the end of Breakfast at UMHealth. Thank you very much, Dr. Tan, for that really interesting topic and insight into vocal cord palsy and injection. I think if no other questions, we close this meeting. Thank you very much, everyone.
Thank you.